Good afternoon. Today our section will be in English. I will do my best to speak English. So we are glad and proud to have here first Professor Julie Kornfeld, that is Vice Dean for Education and Associate Professor of Department of Epidemiology in Columbia University. And also the Chair of Epidemiology, Professor Charles Branas, who has, I will read a little bit of his curriculum. Professor Branas has conducted research that extends from urban and rural areas in the U.S. to communities across the globe, incorporate place-based interventions and human geography. He has led win-win science that generates new knowledge while simultaneously creating positive real-world changes and provide health-enriching research for local communities. His pioneering work on geographic access to medical care has changed the healthcare landscape, leading to the designation of new hospitals and a series of national scientific replications in the U.S. and other countries for many conditions, trauma, cancer, stroke, and many others. His research on geography and factors underpinning gun violence has been cited by landmark Supreme Court decisions, Congress, and the NIH director. Dr. Branas has also led large-scale scientific work to transform thousands of vacant lots, abandoned buildings, and other blinded spaces, improving the health and safety of entire communities. These are the first citywide randomized controlled trials of human right remediation and have shown this intervention to be highly cost-effective solution to persistent human health problems like gun violence. He has worked internationally on 4 continents and led multinational efforts, producing extensive cohorts of developing nation scientists, health programs for entire nations, and worldwide press coverage. Thank you very much, Professor Charles, for being here. I want to inform you that your lecture, our meeting, is being transmitted by the internet in our site, and by the internet in our site of the Academy. It is being transmitted on live.
Wonderful. Thank you very much. Is this on? Can you? Okay. So I want to say thank you so much for inviting me, Vice President. It's just a joy to be here and have an opportunity to speak to you today. We spoke a little bit before about many of the interests of the Academy, and I want to tell you about some of the work that I've been doing. And I have to say that the Department of Epidemiology in the School of Public Health that I lead has many different interests, ranging from chronic diseases to infectious diseases to trauma and violence. And today I want to talk to you about gun violence as a mixture of these, and what is a relatively new field of study in epidemiology, what we can learn from other fields in terms of preventing gun violence and applying traditional methods of epidemiology to the problem. So how do I advance this? Do you have the... Ah, here he is. Thank you. Can I send up there? Ah, oh, God. So, gun violence. Gun violence is a disease. It's really quite interesting to think about this. And in the U.S. and other places, perhaps in Brazil, the idea of this as a disease is perhaps unusual and something new for people to think about. But I want to try to convince you today that the medical and the public health communities have an equal stake, an equal opportunity to help reduce and prevent this problem that plagues both our countries. an equal stake along with the law community and the law enforcement and police communities. So I'm going to start by giving you a little parable about in the U.S., about births and deaths. So in 2010 in the United States, we had about 310 million people in the country. About 4 million people were born, and about 2.5 million people died. So it's a reasonable fertility rate for the country. However, this is the first time in 2010 in U.S. history where we had one gun per person in the United States, as many firearms as people, yeah? Although firearms were born at a much higher rate, about 5.5 million firearms were created in that same year, 1.5 million more than people, and only about 100,000 firearms died, yeah, were left out of the system. I mean, these devices are designed to last for quite some time, for centuries. We don't live for centuries on end, obviously, and so if you, I'm not a demographer, but if you manage to do this out for the United States, this is where we're headed, yeah? So we are awash, we have many, many firearms, and some of the questions have been, well, what's the value of the firearms to begin with? But also, what are the risks or that they might present to us? And there's been a lot of focus on this and what to do, not about the guns specifically always, but about the injury that comes from those firearms. And we've been left to ask this question, right? So what are some better ideas that we might have about firearms and weapons? What can we do that doesn't only focus on the firearms themselves? And it's a very challenging, very creative opportunity for us as public health and medical professionals to begin to address this problem that doesn't seem as if it's getting any better in the U.S. and seems to be, if anything, growing in countries like Brazil and other parts of the Americas. So in the United States, we have a terrible division between what we call red and blue America, and this has played itself out in the recent election. In red and blue America, guns are a top contentious issue. There is this challenge between what I'll call urban cosmopolitans, that is our cities, and rural traditionalists, and that is our small towns around the United States, who are absolutely polarized. And they cannot agree on what the value or the risks of firearms are. And by the way, this challenge spills over into scholarship and science. So scientists are equally nasty to each other, and there's a lot of polarity in terms of what they do. And there's a base question of, are guns protective or perilous here in the U.S.? This was a survey that was done in the United States several years ago that was asking people a lot of different questions, but one of the questions was, if I gave you a list of topics in the U.S., what are the topics where people are not willing to listen to the other side? And guns was one of the top 3 issues. And in fact, this is about 6 or 7 years old, this survey, and guns have now risen up to one of the top 2, if not the top issue in the United States, where people are simply not willing to listen to the other side. They're very set in their ideas about what should be done about firearms, or not done about firearms. And this plays itself out in terms of the urban cosmopolitans and the rural traditionalists that I was talking about before. A study we did many years ago looking at all 3,000 counties in the United States in terms of what is the risk of dying from a firearm. Most people, I think, if you ask them, they would talk about the risk as being a risk for the big cities in the United States. That was the big threat. That was where you would go, and that's where people would be shot. But in fact, you can look at, I think I can reach this. This is the big city for homicide, for murders with firearm. But if you look at going from the big city to the small towns, actually small towns in the United States have a higher risk of death from firearms. It's simply that people aren't shooting each other, they are shooting themselves. So the gun suicide risk in our small towns in the United States is about the same or more as the gun homicide risk in our cities. And so this was news, upset some people. This was news that that was surprising to some, not to us who have been studying it for quite some time. And it really is asking this question, are urban cosmopolitans and rural traditionalists really different? Or are we experiencing the same issue? Now, other questions that came up in surveys is this was a common question, and red and blue America were completely split. Do you think having a gun in the house makes it a safer place or a more dangerous place to be? It is almost exactly a 50-50 split. The American public, half of the public thinks that it would make it a safer place, and half of the public thinks it would make it a more dangerous place to be. So this is very much a contentious and polarizing issue. We did one, so where does science come into this? So epidemiology has been studying this now in the US for 30 years of whether is a gun protective or perilous. The basic question, should I have a gun around or not? And we contributed one of the studies to this. You can see this bottom study. But someone finally did a meta-analysis, and that is a study of studies. This is very recent. This is only 2 or 3 years ago. A guy at the University of California did this. And if you take all the studies and pool them together, the risk of being shot with a firearm, if you have a firearm near you or in your possession or in your home, is about twice as large on average from all these different 6 studies that had been done at the time. Now, these studies have their limitations, but they are definitely suggesting that firearms perhaps hold some risk. And even though what we call successful defensive gun uses, where individuals are able to defend themselves successfully, these do happen every year, but they're actually quite rare relative to this. And on average, having a firearm around may not give you the protection that you think it will. So that was one thing. This generated this particular study of ours, and then this one, this pooled estimate from this meta-analysis generated a lot of thoughts and challenges in the U.S. And in fact, when we put this study out, the firearm lobby in the United States made us the chief target. They put us on the front of their magazine. And by the way, the gun lobby in the United States is and you all are familiar with lobbying organizations, political lobbying organizations. It is the largest lobbying organization in the world. The largest and most organized lobbying organization. They exceeded the American Association of Retired Persons some time ago. It is a over 5 million member organization. And so when they want to target your research, and they called our research goofy, they said that it was junk science, and all of this was not coming in, when they target it, people notice. And in fact, this elevated our work in the eyes. At the time, the U.S. Supreme Court was considering a landmark decision, the first time in U.S. history, about possession of a firearm. And so this was very much brought to the fore. And one of the things that challenged me about this coverage from the National Rifle Association was, and I always show this to my students, I say, what's wrong with this title? I mean, they were arguing that we were saying gun ownership was a disease, and that is exactly not what we were saying. The disease here is the outcome, potentially, of gun ownership, and that is gun violence and being injured with a firearm. And so I think there's a decent amount of education that needs to go on in terms of this space, not only putting forward science to our colleagues, but also to the general public and to organizations like this and policymakers who are very much influenced by organizations like this. So in the U.S. as well, so I'll go into just a tiny bit more of the U.S. politics on this issue, science to study this as a biomedical issue has also been heavily hindered. And in fact, at the Centers for Disease Control, which have been attempting to study this since the 1990s, in 1997, there was this is what's called a funding rider. So every time there's an announcement for grants from the Centers for Disease Control where they want to fund a scientific study, this information sits at the bottom of the grant that says no activities can affect the passage of any kind of local legislation or policy related to firearms. And this was added in 97, and what you can see, this recent study, the scientific publication rate fell off dramatically in terms of studying firearms scientifically in the United States. So this scared, when this sort of thing comes up, this scared a lot of scientists, particularly young scientists, about thinking whether they wanted to make this a career choice to study this particular disease. Now, this would never happen for cancer or heart disease, but this particular issue was something that with lobbying, non-scientific lobbying, really influenced the science and the science that was done, and we are left with a lot less information about what should we be doing about this problem in the United States. The National Institutes of Health as well. This is work that we did putting these data together years and years ago. But the NIH, and I don't know, for those of you who may or may not know it, the National Institutes of Health is the largest scientific funding agency on the planet, bigger than anywhere else. It's a massive amount of money. And you can look at, for some diseases, they are devoting roughly, for cholera, for instance, they're devoting, for every 2 cases of cholera, there is one major $1 million scientific award. And you can go down the list, and for each of these, for about every 5 cases of these infectious diseases, there's about one major award. But for shootings, if we think of these as a disease, the U.S. over this same 40-year period has accumulated more than 4 million cases of shootings in the U.S. We have about 100,000 shootings a year in the United States, but we've only received 4 major NIH awards to look at this problem. So 1 award per million cases of disease per decade is simply not enough to begin to answer this question scientifically and to inform policymakers on what should be done next. So this needs to be enhanced. And I will say that when the shooting happened in Connecticut, the shooting in the elementary school, which some of you may recall, the horrible tragedy, scientists at the University of Chicago and with our collaboration and other universities, about 25 major universities in the U.S. and over 100 scientists, signed a letter that went to the Vice President of the United States as part of a commission. This commission did indeed generate a call for proposals from the National Institutes of Health in the U.S. that actually used the words firearm violence in the call for proposals. It's the first time in U.S. history. Unfortunately, this was 2013, and they've just sunsetted, they've just eliminated, again, this proposal. But it did produce about $20 million in research on firearm violence for the first time ever. So we're very happy with that, but we'd like to see that continue. But it's one of the opportunities that, as scientists, we, in this particular, in gun violence research, we not only have to advocate and do our science, but we also have to advocate for any resources at all to begin to answer this very, very important question. So part of the question I often get from the general public is, well, why is this even a concern of yours? This should be a concern of the legal system and of the police. This is a law enforcement concern in any city in the United States, in any town. There's no reason that the medical system or the public health system should have an issue here. And part of my answer is, well, very simply, if you're shot in a city in the United States, where are you going to go? I mean, if you manage to survive, you will go to a trauma center hospital and you will use medical resources. If you die, you will go to a medical examiner in some morgue somewhere. So the medical system is always involved when a shooting occurs. And we like to think of this, it's very similar from a public health or an epidemiologic standpoint to an infectious disease. I mean, you can imagine in epidemiology, we talk about people, places, host agents, vectors, and environments, right? And so if this were dengue, you would have a mosquito or malaria, a mosquito, the plasmodium would enter into a host, and there would be a swampy environment that surrounds it. This is exactly analogous to gun violence, where you have an agent and a vector, a gun and a bullet, a host that is receiving the injury. Yeah, it just so happens that the pathophysiology of that disease happens in a fraction of a second. It doesn't take days, weeks, or even years. Just happens in a fraction of a second. And oh, by the way, there is also an environment, in this case I'm putting a city environment up there, that might be leading to this. There's a context that might be generating this. And in fact, part of my work, because we focus so heavily, as I was saying before, on the firearms and the hosts themselves, part of my work has really started to think, well, is there some value to focusing on the environment and thinking about this? And when I talk to infectious disease epidemiologists, they are very much into the value of treating the environment, the same way you would treat a patient. So this is a quote that says, if a brackish tidal pool is breeding mosquitoes, filling it in may be far more likely to continue reducing malaria years after the funding has run out, has finished, than expecting local community members to continue to apply larvicide on a regular basis. There is value here to thinking about the very context that produces the problem in the first place, and perhaps there might be some more sustainable value. Part of this also meets with, this is what's called the health impact pyramid, which was first penned by a doctor named Dr. Tom Frieden, who was the head of the Centers for Disease Control, and was also, coincidentally, one of our alumni from Columbia, from the School of Public Health. And so the impact you have on a health problem is inversely related to some of the bigger issues in society. So that counseling, education, and medical care have impact, but as you move down the pyramid, things like immunization campaigns have perhaps larger impact on the population and population health, and then changing places and even thinking about changing poverty or other socioeconomic factors might have a major impact. So we saw this and we began to think, well, are there opportunities for changing places that could impact gun violence because we weren't having success? The medical system was having some success with trauma centers in the United States, but going out into communities and trying to teach people not to be violent was not having as much success as we could. And by the way, this is a good study, it's from London, but police have value, in fact, have great value. When you insert police into a neighborhood, the violence does get reduced. We have good studies of this. But once the police are taken out of that neighborhood, police can't be everywhere at all times. What you see from this particular graph is that the violence comes back to the levels it was before the police came into that space. So we also wanted to think more broadly about treatment effects and opportunities for treatment of entire areas that would be sustainable and that would last long after and perhaps would require much less maintenance and intervention from people. So part of that was us thinking about what are the place-based solutions to gun violence that we might actually impact. And the lab I run thinks about poverty and blight, physical blight to the built environment, visual blight, things that you can see, things like abandoned houses, abandoned lots, the consumption of alcohol, and various other things, business improvement districts, and other things like this. And how might these be treated as if you would treat a patient to change gun violence in neighborhoods? And so we've come up with a number, and working with multiple cities, about a half dozen cities in the U.S., these standard treatment protocols for abandoned and blighted spaces, where a space that is completely unattended to, these spaces on the left of the screen, in a very short period of time and with workers that are from the community, these spaces get transformed into clean and green spaces with a small fence that says the space is cared for instance. This is for our land treatment. The space is cared for, and this is not a place where crime and violence are permitted to occur. And by the way, the space, when it moves from this to this, in the U.S. we have a very big problem with illegal firearms. And those illegal firearms are often stored in spaces like this where it's easy to hide something, an illegal gun or illegal drugs. Converting a space to this really reduces that. And you can imagine these are singular spaces. Perhaps they're 1,000 square feet. Not really that large, but if you live on a block in a city where there are 20 of these spaces, and over the course of a 3-week treatment period, they all get converted into clean and green spaces, it's a major change in your day-to-day life. It's a major difference in what you see every day when you walk out of your door to go to school or work. So it changes not just, perhaps it changes your mental health, your stress levels, and your interaction with the outside community and with your neighbors. So these are standard protocols for treatment of spaces that can be reproduced and have been reproduced in multiple cities around the U.S. And so we've studied about 20,000 of these spaces in different cities This is the one I was just telling you about for vacant land that's been abandoned, but we also have a series of different standardized protocols that we've studied and tested for abandoned buildings, for buildings that have become dilapidated in the U.S. And so I guess one of the bottom lines here is that we've looked at the gun violence problem around these spaces in a very controlled scientific way. And indeed, there's a significant drop of almost 40% when you go from the spaces on the left to the spaces on the right. So these are very significant shifts in gun violence for the neighborhoods in which these spaces are in the condition they are on the left. And this is very inexpensive. So we've done cost-effectiveness analyses around this, and for about every dollar that you put in, there's almost $80 that's returned to the taxpayers of that city, because gun violence is a costly affair. It doesn't simply take the costs of the police to respond to it. It takes the costs of the medical system, as I've just told you. It also takes the costs of the pain and suffering of the victims, of their families, and in the U.S., for instance, in cities that I work in, for instance, cities like Philadelphia and Detroit, in a 30-year period, these cities lost over 1 million people who left their cities and created spaces like those on the left because of the gun violence problem in those cities. So the city itself, the economic repercussions of this kind of violence is dramatic, and it will alter an entire city's future if left to continue. And we think these treatments, which are structural treatments to spaces, which are scalable to the entire city because they cost so little, and also have a lot of sustainability, are quite valuable. We've begun to look at these. This is for the city of Philadelphia, for the vacant land, and for the abandoned housing. We've begun to also look at these using randomized controlled trials, the same way you would test if you thought that, does aspirin reduce headache or something very simple medically? You would randomly assign some group of people to get aspirin and some group of people to get a placebo. We've done the same thing with spaces and buildings in the city of Philadelphia in a random assignment. So this is as high a level of science as you can get, and we're finding roughly the same thing here, that gun violence, perhaps it's not 40%, but it's 27% reduction in gun violence, which is extremely high around these spaces after they get remediated and changed. And as well as other nuisances, noise complaints, public drunkenness, these other sorts of things also go down by a significant and dramatic amount. And we're calling this win-win-win science. So the first win is for science, that there's scientific evidence created and that new knowledge is created. The second win is that we've used federal dollars, whether we found scientific evidence or not. Federal money has been used to alter, in this case, thousands of spaces in cities around the country. And the third win, which speaks to my earlier point, is that this is very politically acceptable. No one in the U.S. is opposing this. Particularly the firearm lobby has no opposition to this. This is not in any way an attempt to take away people's firearms. It is simply a way to reduce the trafficking in illegal firearms and ultimately the violence around those ways. And then the last thing is there are many co-benefits that accompany this. So we had the opportunity, because these are experiments that we're doing, these are citywide experiments, but to look at this and say that, well, not only does gun violence go down, but people go outside more. So perhaps there's opportunities here for improvements in cardiovascular issues. People also, depression has gone down by a significant amount, and other reports of mental illness have gone down by a significant amount in the areas where these conditions are shifted for this very little bit of money. So there are various co-benefits that come along with this. So I'm just going to conclude by saying that, we're really trying to make red and blue America purple America. And in purple America, we recognize and we try to work with the fact that in the U.S. we have more guns than the next 10 highest nations combined. We have many, many firearms. We have about 100,000 people that are shot each year. And something else that people can come together on is about 30,000 of these victims of shootings are children in the United States. And nobody is accepting of this. This is an issue, and it costs the United States about $100 billion a year from the best economic estimates, our gun violence problem. And people agree that it's quite serious. If you ask most Americans, they will say it's very serious. And when you look back at this chart of urban cosmopolitans and rural traditionalists, this is important to show the difference between our big cities and our small towns. But part of the message here is if you add these up, really the risk of gun death in the United States is the same, whether you live in a big city or a small town. And we need to start making that clearer to the public so that they can get behind issues of gun violence. So I'll just pass through this. And I just wanted to end by giving you, and I want to hear your thoughts here, giving you what I've learned a little bit in Brazil. I had the opportunity to work with a guy at the University of Pennsylvania years ago, James Machinko, who was here in Brazil studying gun violence. And I'm just going to call up some of his old work, and I wonder what you all think about it. Now, unlike in the U.S., in fact, when I was a paramedic riding with fire departments in Baltimore and Philadelphia in the early 1990s, Brazil and the United States were about the same in terms of the homicide rate for the countries. For the U.S., that was a high point in our homicide issue. But at this point, Brazil, the homicides have grown dramatically to a point where they're almost 3 times that of the U.S. from what I see. But like the United States, what I've read is that the homicides here in Brazil are also dominated by firearms. So firearm violence remains a major issue here. But some of the bright lights are that in Sao Paulo, that from 2001 to 2007, much like New York City in the 1990s, homicide went down and was cut in half. So that's very impressive, and I think part of the question is why? We actually don't really know why in New York City the homicide went down so dramatically in the 1990s, but it's a worthwhile question to try to figure that out. And the other work, and this is work by Getzel and Kahn, the other work was James Machinko and Maria de Fatima Marino de Sousa's work of the 2003 gun law that was passed in Brazil, where in the year that followed, their estimate was that 5,000 gun deaths were indeed prevented by the law. And I love this, and I'm just going to close with this, that this is gun violence in Brazil. And you can see it's on a steady, steady rise. And the instant, it's fascinating, this is textbook epidemiology time series, the drop is very, very soon after. There's a significant drop in the gun violence after the 2003 gun control law. So I think that, in closing, just gun violence is, we want to begin to think of it as a disease, if that helps, and that the public health and the medical community should be very active in this, the same way the law enforcement communities are. And there are successes here to be pointed out, to be studied, and things that we can put out there in the public to perhaps have an impact on this in a sustainable way. Thank you very much for the opportunity to say a few words.
Thank you, Professor Charles. I would like to invite you to sit here. And I think this topic of gun violence is very important for all of us, especially in Rio de Janeiro, where we live a kind of urban war. Some colleagues that work in emergency unit, they always say they are working a war unit because people come to them with gun violence frequently. And I have never heard such important subject about gun violence, showing some data. How can we prevent gun violence, not only taking out the gun, but also improving the environment, improving the place where those people live. Now that we are having some important violence here in Rocinha and other places in Rio, some people are talking in the newspaper, in the media, that the way to prevent violence is to increase the environment, to be a better environment, to have culture, schools, health, and even the buildings should improve So people living better, they have more condition to fight against violence. So I would like to open for question of our academic Eliette.
In Brazil, thank you for your conference. It was very nice. Here in Brazil, we have talked a lot about the decrease in violence in New York due to the political adopted by Giuliani on zero tolerance. What do you have to say about that?
I think that the best evidence we have, and I would encourage you to read a book, Frank Zimring just wrote a book about this. I think it's unclear what the implications of zero tolerance. There's value to strong policing, but it's unclear whether that alone was what led to the drop in the 1990s in New York City, which, by the way, was such a large drop that it led to a drop in homicide for the entire United States. Mm-hmm. Now, other cities that had similar zero tolerance policies, Chicago's a great example of it, there was no shift. It's challenging to put it all on policing. I think it's a testable question whether the shift in construction and other environmental changes in New York City over the same period perhaps was part of or a major explanation for the reduction in violence. New York City has visually and the built environment of New York has changed dramatically in that period.
Well, because here in Brazil, in Rio, we have a state just north of us called Espírito Santo, where the governor managed to decrease very much the violence rate. And since we are in such a catastrophic situation, yes. People are even talking about importing him to become our next governor, because, I mean, we are really panicking here. I mean, the situation last Friday was, to my mind, close to unbearable because, I mean, the city kind of stopped.
There was a slide I had on policing where policing is very successful, yes? So it reduces violence, but it lasts as long as the policing is present. So maintaining that level of vigilance in policing, which may have other unintended consequences, by the way, but maintaining that level of vigilance in policing is difficult, and it's costly
very much
to do. And so there might be some so I'm not making a recommendation that you don't pursue policing strategies. Those are key to this. However, I would also think that, and the recommendations we make to cities is that along with policing, that there are strategies that also change the basic structures and conditions of the environments that the people are living in over and above simply just more police. And then that might contribute to a much more sustainable reduction in the violence as opposed to something that will last as long as the police are there, right?
Thank you.
So thank you for your question, by the way. It's a very important question.
Walter.
Well, thank you very much for your presentation. It was very interesting. I have one question about, it would be very interesting to see those numbers you showed us normalized by the population. Because you said that between 96 and 2003, the number of deaths increased from 15,000 to 20,000. That's a 33% increase. And on the other hand, the population in Brazil increased from 9 million in 1970 to 210 million in 2015. So I think they're sort of going together, if not the other way around.
Yeah, I think that's a very important. Thanks for saying that. I think that it would be interesting to look at the rates for the country. Have the rates also changed and gone up? Even though there's 15,000 more annually, perhaps the country's population has increased by that amount as well. So it might be steady state. I think it's a great question.
Thank you.
Yeah, thank you for asking that. Yeah, we'd have to look into those numbers and get them. Again, that was me just pulling some numbers out to take a look at what was going on. So maybe you can tell me more about the growth of the population in Brazil. I mean, has the city populations grown dramatically as well over the same period? And I think those are questions to ask.
Yeah, I don't know exactly about the same period between 96 and 2003. The numbers I gave you were from 70 to 2015. And went up from 90 million to 210 million.
Yeah.
It's at 230%.
Yeah, it's amazing. Yeah. Important to take that into account. Thanks for pointing that out.
I think one important point that you show us is that we are not going to win the gun industry by forbidding guns, because as in Brazil, they start to work in the black market and have guns for everyone. The guns just become more expensive if you forbidding the guns. But you should improve the life of people. No? You should give people opportunity, social, culturally, and health opportunity to improve their lives. And so gun is not so important for them to become safe, to have this idea of safety. Any other question? Yes, please.
Hi, Charles. It's more a curiosity than it's a question, but it's more curiosity. Here in Rio, in Brazil in general, we have many police violence. Does it count as gun violence too?
Police violence?
Yeah. Do you count it in the U.S. as gun violence too?
We count it. It does not figure into the numbers I showed you. It's an independent category, what's called in the U.S. legal interventions. So acts of police violence, which have been growing, and the numbers have been growing in that category, are not counted in the numbers I showed you. And actually, for the very first time, only in the past few years in the U.S. have people begun to study this. The same way that you would study gun homicide. These acts of legal intervention. So yes, and I think it's very important for us to begin to think about that a little bit more as part of the unintended consequence. So.
Thank you.
Congratulations for the presentation. Interesting. The cause of death in Brazil, the external causes that include gun violence are the major causes of death in Brazil, even in the public and the private sector. But it's interesting to know that in big cities it's more common homicide, in small cities it's suicide.
Yes.
Then the gun is not related with homicide. Have to have violence together, because I think in small cities the depression make more sense. The question is that you told that the environment change are as a therapeutic intervention.
Yes.
And more specific, architectural or buildings. And about services, education, are you study the other type of interventions?
So we have not been studying education specifically. We have done in the past, I shouldn't say that, we have done direct behavioral change studies for like teaching children conflict resolution and non-aggressive management of their behavior, that sort of thing. And those have been actually quite successful, but one of the problems with those that we found, and again, this is a decade or more of doing this sort of work, is even though they may be successful, they only last as long as the program is maintained for those children. And once the money runs out and the social workers or the public health workers that are in their school or wherever leave, the acts of aggression return and the violence returns. And by the way, these are quite expensive to implement these programs. Your other question was, you said the school system. Oh, you said about goods and services that are provided to areas. So we do have, a colleague of mine has been looking at what many U.S. cities have done with the implementation of business improvement districts. This is where a commercial, like a commercial center of a city, or maybe a series of different neighborhoods want to start a different new commercial street or something like that with new businesses, and they want more police, but it's not really about policing. They want to clean that area, provide opportunities for the businesses to grow through various financial incentives. And then, interestingly, one of the things that, one of the reasons we think that there are reductions in crime and violence for these business improvement districts is that for very little money you can have people show up every single day and clean up. Pick up the trash, make sure the trees are pruned, clean the windows. I mean, I know it sounds a little bit disconnected, but we're finding significant reductions in crime in cities like Los Angeles and Chicago when these business improvement districts, for very little money, get implemented and put into place, offering people services, but also offering them a clean and safe environment to come shop in, for instance.
It's very interesting. Thank you.
Thanks.
Now, Professor Julie Kornfeld will talk a little bit about the possibilities of work together with Columbia University. I would like to remind you, Professor, that your speech is being transmitted by the internet to many students and young professors, so thank you for coming.
Thank you. So I'd like to just talk a little bit about public health education, some of the opportunities that we have and the approach that we take at the School of Public Health at Columbia University. I like to use this map as it shows from a global perspective the kinds of topics we talk about when we talk about public health and what are the range of areas that we work in and that we train our students to work in. And as you can see, they range from urban health and the kinds of topics like Dr. Branas just talked about, but also around mental health and climate and environmental health, food policy, and many other areas of importance. And students in our program and faculty work with our students to look at these kinds of issues to really make broad and impactful changes at a population level. I think most of us, or many of us, are familiar with a definition of public health as opposed to a medical definition where we may treat an individual or look at to solving problems one patient at a time. In public health, we're really training our students and working in our research to work collectively as a society to assure the conditions for people to be healthy. So what does it take when we collaborate and work together to solve problems at a population level? I show this diagram because I think it does visually indicate to us that when we are looking at public health, if you think very simply at what would be a cliff and how people fall off the cliff, at a medical care and tertiary prevention, we're working out people have been injured, and we maybe have safety net programs to help alleviate the injuries and put that into solve those problems. But in public health, we're really looking very far upstream at addressing what are the things that cause, or the causes of the cause, I often say to my students, what are the things that cause the people to take to violence in the first place? Poverty, lack of access, lack of education. And unfortunately, in countries like US and Brazil, we're not only talking about what does it take to work upstream and how do we train our students to work upstream, but we're also looking at two very unequal systems where some people have not only access and exposure to poverty and poor education, but also differences in exposure. We see this in many areas around air pollution and children who suffer from asthma who live in poor and poor housing conditions. And so we're not only talking about what are the causes of the cause and how do we address them, but how do we address them and alleviate and in a perfect world bring these two systems together. So structural inequality. I'll refer again one more time to the pyramid that Dr. Branas showed, because we use this very much to think about our education and how we train our students, and that what is it that we can train how do we look at public health as an interdisciplinary program, and we've redesigned our curriculum in order to re-establish our connection to interdisciplinarity. So we are often, we're talking a lot about violence today, but if you think about issues around obesity, if you think about issues around climate change or environment and its impact on health, we are not going to solve those as physicians or even as public health professionals. We need to collaborate and work across sectors. We need to work with urban planners and architects, and we need to understand how to alleviate the larger conditions at the base of this pyramid that allow us to also change the context so that people can make healthier decisions and it's easier for them. So in fact, in the United States, one example we often talk about is our success in tobacco control was not necessarily due to physicians telling patients to quit smoking or even to billboards or signs that we put up, but when we were most successful in getting children to stop smoking is because we had policy implementation that increased the cost of cigarettes. And so in doing that, young people who were pretty cost sensitive stopped buying cigarettes, and cigarette smoking plummeted. So what we're trying to do at the School of Public Health and in collaboration with many of our partners across the globe is to work at many levels of this pyramid and to train our students to do that. So we also talk a lot about training our students to be epidemiologists and biostatisticians, environmental health specialists, as well as and social and behavioral scientists, and it's very important that we give them rigorous training in the scientific methods to do public health science. But we also want to train them to work in situations that look like this. So in public health, if you see a health department or a Ministry of Health at the center of this dialogue, in order for us to effectively solve the problems, we need to train our students to work collaboratively and in partnership with many different entities and sectors. We have to work with the police and emergency medical services. We have to work in drug treatment and with laboratories to ensure that we have the ability to timely diagnose disease and get information out. We have to work with those who collect data, et cetera. So we have to work with our politicians. So I often tell our students it's not enough to know the science, you have to know how to communicate the science, and how do we translate the evidence that we have about what works into action. So these are the things that drive the academic programs in our school. I'll tell you a little bit about our school in general. We are one of the oldest schools of public health in the United States, one of established, we're coming up on 100 years of public health education. We have 6 departments. I'll mention them a little bit in a second. We have 5 graduate degree programs in the School of Public Health, a Master's of Public Health, which is our largest public health graduate program. We have about 800 students in that program from all over the world. Many of them are undergraduates, many of them are physicians, other scientists who seek training to give a more broader-based skill set in addressing population health. We have Masters of Sciences, a Master's in Healthcare Administration, which looks at the integration of policy and management and public health, a doctorate in public health, and PhD programs. We also have many dual degree programs where we're training students in collaboration with other schools, so a law school or a JD, MPH, or a Master's of Social Work in combination with a Master's of Public Health. We have, as Dr. Branas talked to you about his work, many funders, many researchers who are funded by the National Institutes of Health in a broad areas of public health, and those programs of research are conducted in over 100 countries around the world. We have about 1,400 students in the school, to give you an idea, and we have about 400 faculty in the School of Public Health, about 140 of them as primary faculty, and then other faculty who are affiliated and have joint appointments in schools of medicine, schools of law, and also involved and engaged in public health practice in the public and the private sector. We have 6 departments, as I mentioned, and these are fairly traditional for schools of public health in the United States. These are the 6 departments that we have. Dr. Branas chairs the Epidemiology department, which is one of our larger departments in the school. I want to talk briefly about the Master's in Public Health, as I know we may have people listening who are interested in a Master's in Public Health at Columbia. It is traditionally a 2-year program. We redesigned the curriculum very deliberately to focus on the kinds of things I just spoke about, so that we're not just training students with a deep understanding of their discipline-specific knowledge, but we really want to introduce them. So this big blue chunk you see in the beginning is, as we bring students into the public health training, we do interdisciplinary or integrated coursework across the continuum of public health, so that we're training our students not just to think like epidemiologists or biostatisticians, but to look at what are the causes of health problems and how do we look across that from a quantitative methods, how do we frame the questions, how do we measure our responses, how do we look at the policy implications and translate that policy, and what is the history of public health around some of those policies, and how does that inform what we do in the future. So we do a very integrated and interdisciplinary core curriculum for all of our students, and then our students then transition into in-depth coursework in their specific discipline. They belong to one of the 6 departments of the school, so they will have an MPH, but they will sit within a department of epidemiology, a department of social medical sciences. They have opportunities. We do a case-based learning approach for all of our students, much like a business school would do, where you take real-life case studies and look at their significance, and our students work in small groups to actually apply the lessons learned from historical cases in public health to solving public health program problems that we face now. What are the leadership and management skills that they need? So beyond just thinking of like a scientist, as I mentioned, really being able to advocate, think about what decisions you might make as public health leaders. They are required to spend time in the field and doing it at practicum, so they spend several hundred hours in the field working in a real-life case, with a real-life partner, a community-based organization, an NGO, a government official, a school of medicine, so that they're actually translating the knowledge that they're learning in their curriculum, in their classroom, to the field. We've talked quite a bit about training collaboratively with our Brazilian partners, and really having students who study public health perhaps in New York, but using and working collaboratively with organizations in Brazil in their practicum and in their final projects, so that they're actually working to solve problems that affect the country that they come from and where they will return to work. And that's something we're quite excited about exploring further on our visit here. We do this in a 2-year program, and we also do this as a 1-year accelerated program for students that have training in medicine or other disciplines in the doctoral level. I want to go back just for a second to mention that we also require our master's students to have certificates in one specific area. So you can see that they have an opportunity to drill down very specifically in areas that are of interest to them. Could be around chronic disease, could be around infectious disease, perhaps around climate change and health, and so on. So the idea is really, if you look across the continuum of our education, it's a very deliberate opportunity to train our students to think across disciplines and integrate science, as well as to gain knowledge and skills in a specific area of discipline and knowledge of their choice. Again, I mentioned we have an MHA. This is the Masters of Healthcare Administration. This degree sits in our Department of Health Policy and Management, and really is a combination of management courses, public health courses, and courses in health policy. We also have a DRPH, which is more of a professional practice, so a doctoral level training. The students in this program have already achieved or received a master's degree in public health most often, but sometimes in other disciplines, and are really looking to be trained as public health leaders, as opposed to a PhD, where they're really being trained to be academic scientists in a specific discipline. So the difference is the GRPH is more of a professional practice degree, although many students go into academics and areas of research, but they have a broader knowledge base in professional management, leadership, and practice, as opposed to our doctoral programs, which are very specific in academic programs and sit in the programs of biostatistics, epidemiology, socio-medical sciences, and environmental health. We also offer a range of doctoral programs, training programs, at different levels. So we train undergraduate students in the United States and undergraduate students who are interested in pursuing and exposing them to biostatistics and epidemiological training as they're in their summer, as they're undergraduates and thinking about their next career moves. We have a Columbia Summer Research Institute and an EPIC, something we call EPIC training, which offer short courses, sort of more intensive short courses, some digital, some in person, but more 3 days to 1 week courses, which really give the flexibility for people who are in the workforce to have opportunities to gain skills in areas of public health research and knowledge, particularly in epidemiology, biostatistics, and also around program evaluation and implementation of interventions. And we also offer in multiple departments, including epidemiology, several doctoral and postdoc training programs that are specific to areas and disciplines of study and align very often with our NIH funding areas of research. So I think I'll stop there as an opportunity to give you an overview of the kinds of things we provide at the School of Public Health, and happy to answer questions and look forward to future collaborations. Thank you.
Thank you, Professor Julie. It is very interesting, all these possibilities to work together with Columbia University, our students at our universities, and also young professors to go or to come to Brazil and to work together. We have a Columbia office here in Rio, and I think it will be the first door to get in touch with Columbia University and all these courses, right? Mm-hmm. Yes, okay. So, thank you very much. I would like to thank you all. Thank you for coming, the excellent presentations. Thank you, and it is closed today. Thank you.